There was one thing, if, as Karen was pointing out, safety is really important to intimacy. So, and physical safety, emotional safety, psychological safety. So, especially on the physical front, depending what's going on with your body, it may be important to ask your physician if, to what degree is it safe? Where are there physiologic boundaries? Where might you accidentally hurt yourself with some idea of sex? So that may be a reason to talk to your doctor about it. How to talk to your doctor about it is inherently clunky, mostly because the way they'll probably be a little shifty on it. But this is where you got to be a little daring and say, hey, doc, I really want to talk to you about something that's very intimate. Sometimes you might want to preface the conversation to set it up for the doctor. Sometimes that means because there's students in the room or other people in the clinical encounter, you might say, hey, doc, if you like, it could be a very great teaching moment for students too. But if it helps, you might say, hey, doc, can I talk to you about something, just the two of us, or just the three of us if your partner's there? And then simply wait and say, I'm worried about, if it's a treatment coming up, I'm worried what this might do to my sex drive or my sex life or my arousability, or whether sex is safe anymore. So this new treatment you're talking about, doc, is that going to affect my sexual life? And if so, how? And do you have ideas or anyone I can talk to or think through, how to work with this? That kind of thing. But it will largely fall to you to push the conversation with your doctor or your nurse, your clinical team. Both Karen and I really wish that weren't the case. We wish it were much more normal for any doctor or clinician to bring these issues up, because we see this sexuality and intimacy as essential and primal, part of fundamental human experience. So we got a lot of ways to go on the medical training and clinical encounter world before you can expect those guys to bring it up, but we'd certainly push you to bring it up on your own behalf.
Absolutely. Again, I think that's such a well said, and I think sometimes for people that work with like a cancer center, you're having people in infusion. A lot of nurses, sometimes they can advocate because a lot of times they feel comfortable about bringing it up, or the social worker might, or other clinicians there. But I know in the cancer center where I'm working, maybe because I'm working there, I don't know. It's always an insistent thing. We've done in-services on making an assessment as normalized with sexual health as it would be with blood pressure, temperature, everything that people take when they sit in the office before the doc sees them. And what about your sexual health? Are there problems there? And languaging a few questions. It's been hard because the medical assistants feel uncomfortable about it. So we're having to have people normalize that. And then when we do, it's like, okay, we can do that. And people really, they're kind of confounded. They stop being nervous a lot of times because they aren't expecting that question. And it's a doorway into maybe being seen in a little deeper conversation too. The hope is there. And I think with our palliative care, we include that. I did with BJ when we worked together at UCSF, and then also now where I work. It's part of our screening process for symptoms that matter. And once they're part of the physical spectrum we talk about, because many people, it does matter and nobody's mentioning it. And some people don't want to mention it, and that's okay too. No judgment around it, but we treat it as though it's like everything else that's important to the degree somebody wants to make it that way. And if they don't have somebody in their area, we try to find clinicians. It's really hard still to find trained, good sex therapists that are reliable, that aren't that are people you want to send people to for treatment still. But we're getting better in the mental health world about training people as well. So it's still going to be a long time though. So I mean, if you have a good rapport with your physician and want to just shake things up for playing with them, you can watch them squirm, and you can say, this is like what's really important, and I don't know if you feel safe enough with that person, and many people do over time. You won't derail them. They'll probably appreciate the break to become alongside you in the humanness of this versus them being always an authority, because nobody's an authority on this. And I know sometimes when I've asked on patients' behalf, what's important to them, an example, a cancer patient who's on immunotherapy, and they loved oral sex together, she and her partner, and what nobody seems to know is that if she has oral sex while she's getting the immunotherapy, is he going to get a dose of it as well? And asking that question was, it kind of went to the big pharma companies, and so far we haven't gotten an answer back, but nobody had any data on it. And they said, that's a really good point. So going back to the earlier times of chemotherapy, where it's still pretty toxic and secreted in different ways for people, we were kind of just using those axioms, but a lot of the gene therapies and immunotherapies now change every 6 months. So nobody's really looking at the side effects of that yet. I think some of the bigger cancer centers are in Canada particularly are starting to look at that as a quality of life issue that goes along with everything else. And it's important, if that's how you've connected and you enjoy those kinds of sexual practices, then why not, but nobody seems to know. So to be able to talk about that and decide what can be safe for you and your partner to still work with sexuality issues or practice different sexuality kind of processes that give you resilience and care and comfort and connection. And that'll really confound your physician, but it actually may be a really good discussion to drop you at pretty nice levels with them. So
Yeah.
Awesome. Well, thank you both very much. That was really great conversation. Appreciate it.
It was fun.
Thanks for being here, Karen.
I'm honored.
Thank you, Karen.
And your audience is lovely. Thank you.
It's so lovely working with you again in real time, Karen. Thank you, thank you, thank you. More to come.
Bye, guys.